valve. We also should look at PR segment elevation as well as depressions. Now coming to the QRS complex, it's a second major deflection. It represents the ventricular depolarizations. So we know that atrial depolarization is represented by the P wave, ventricular depolarization is represented by QRS complex, and of course the T wave represents the ventricular repolarization. The U wave represents the late repolarization in Purkinje system. So QRS complex duration, normally we know it is 70 to 110 milliseconds, and the normal transition zone of QRS complex occurs between V2 to V4. So that is how we, and also we look at the QRS voltage complexes, because as you know in left ventricular hypertrophy the voltage is increased, and some of the pathological condition like pericardial effusion you have a low voltage. The QRS complex consists of the Q waves, which are initial downward deflection, and an R wave, which is a initial upward deflection. Then an S wave, it's a negative deflection, and the R dash is a second positive QRS complex. So the relative sizes of the QRS are reflected by the upper and lower case letters. Now this is how the normal ECG, sometimes you know that how the nomenclatures are like RS, the small r, big S, that means the small r is smaller than the big S. RS, how it is reflected in how we the nomenclature which we use for representing the ECGs. In the same way, you can look at the downward QR, QS, RSR, RSR dash, RR dash, like these are all the deflections and which are used in the normal QRS complex. So the genesis of QRS complex, as you know, it is from the endo to epicardial depolarization which occurs. Now a Q wave is normally we see a small Q wave of any size in leads 3 and AVR is normal. This is what we should do. So third lead, even though sometimes we see a deep Q waves in third lead, we should not take it as pathological, because most of the time it is considered as physiological. Of course AVR also we have, but a non-pathological Q wave, that means when we look at the Q wave, it should be less than 40 milliseconds in duration and less than 25% of the height. That is what the ensuing R waves. So if you look at the ECG, if you look at the Q waves, if it is more than 1/4 the height of the R wave, the amplitude, then in that case it is pathological, otherwise it is non-pathological or physiological Q waves. So that is one. The second thing is that we also look at the QS complex is very common in V1. Sometimes rarely we can see in V2 also. We should correlate clinically. Now R wave, it's can be absent in V1, though absence is in V2 is very rare, because sometimes we don't get R wave in V1, but in V2 rarely it is absent. Most of the time, maybe most of the time it is present. So R wave amplitude increases from V1 to V4, and the tallest R wave is usually V4 followed by V5, and normally V6 R wave, the amplitude is smaller, less than that of the V5. That we should know, that the V6 have a smaller amplitude compared to V5. And precardial transition of RS pattern occurs usually between V2 to V4. S wave is prominent in AVR, as we have suggested physiologically, and large in V1 and larger in V2, and then progressively S wave becomes smaller in V3 to V6. So the basic component of ST segment is that it begins at the end of the QRS, J, that is a J point, ST segment, which is very important for many pathological conditions, as you know, and it represents the unchanged polarization between the end of depolarization and also the beginning of the repolarization. Normally it is isoelectric, but if we have some amount of deviation can be there up to 0.1 millivolts, and otherwise we always take that ST segment, TP segment as an isoelectric baseline for measurement of ST elevation as well as ST depressions. The T wave represents ventricular repolarization. It is smooth and rounded, asymmetric, and always it is inverted in AVR, and it's always upright in 1 to V4 to V6. may be upright or inverted in third and AVL. The QT interval, very important. It is also a representation of ventricular depolarization as well as repolarization cycle. That is, combination is the QT interval, and it begins at the onset of QRS and ends at the end of T wave. Corrected QT interval is very important when we are measuring QTC, that is corrected QT interval by Bassett formula, which is QT divided by RR interval, which is has got men and women have different. This one, it should be less than 0.43 QTC in men and less than 0.45 in women. U wave is another one. It's a small deflection that appears later after T waves, and it is it usually represents the late repolarization which occurs in the Purkinje system, and normally it has not much significance, except that in hypokalemia it can be very prominent, where we measure QU interval. Then the QRS axis is also, as already Dr. Subramaniam has spoken, it is varies from -30 to +90 degrees in normal frontal plane. So that is how. Now the other important thing is that this is already been discussed. Now coming to the rate and the rhythm, we know that the sinus rhythm is a normal sinus rhythm is sinus. The P wave morphology is normal and similar. Each P wave is followed by QRS. What is sinus rhythm? That is the definition of this. And each QRS complex is preceded by a P wave, and PR interval is essentially almost less than 10%, so that there is no much irregularity, and heart rate varies between 60 to 100. So this is a normal ECG. Some normal variants, will have a look at it. So one is sinus arrhythmia, then there are something called athlete's heart, then there are something called early repolarization syndrome, there is something called persistent juvenile pattern, and sometime RSR in V1. So these are all normal variants. So that's what we get in when we see a ECG. These things we should keep it in mind before we conclude. This is a normal ECG, but sinus arrhythmia means what happens is it's a normal sinus rhythm only, but except that the P interval varies for more than 10% with acceleration rate during the inspiration and slowing down during expiration. So particularly you have to be very careful when you are diagnosing, because sinus arrhythmia is very easy to so when you look at the PP interval, only thing is that acceleration occurs during inspiration and the slow rate occurs during the expiration. Sometimes it can be very marked, clinically important. We should be in a position to differentiate between the clinically malignant arrhythmias. This is how the sinus arrhythmias looks like. Here you can, if you look at it, the PR interval, there is always P and QRS relationship is well maintained. Only the rate is varying during inspiration. It is increasing, and during expiration it is less. So that you will have look like a pause. It is not a pause. It's a sinus pause only. Then athlete's heart is another ECG which is often seen in trained athletes. They will have they will have significant sinus bradycardia. As you are well aware of it, the greatest athletes, most of them who are very athletic, have low heart rate, the basic heart rate. Sometimes as low as 34 has been represented. Boris Becker has intrinsic heart rate of 34. And at the same time, these athletes they have some varying type of ECGs in their this one particularly. They can have sinus bradycardia, they can have first degree AV block, even in some cases they have increased QRS voltages, and labile T inversions, biphasic T waves are all present in athlete's heart. Sometimes they get even second degree AV block, Wenckebach block is also been reported. Junctional escape rhythms are being reported. So these things are all because of the increased vagal tone, and of course these changes becomes less pronounced as their training or their athletic training comes down. That's the thing. The other important point is early repolarization. This is also normal variation. You know that most of the time we have to keep this in mind, because there's sometime we by mistake we can also conclude it as an acute MI because of the ST elevation which occurs, but we can easily make out this early reposition. It almost in 1 to 2% of general population it is present, particularly males it is there, common in athletes again, and there is some amount of concave upward ST elevation, minimal ST elevation, and prominent J waves in the mid precardial lead. Often most of the time this occurs in the V4, V5, V6 area, leads, not like an acute MI where you get a selective lead according to the position of the myocardium. Often it is associated with a slow sinus rate. That is another thing when we look at early reposition. I thank the organizing committee for giving me an opportunity. If you have any questions about this normal sinus beat, please you can. Yeah, that's what I told. Whatever I spoke about these 5 components, that is juvenile. Another thing which I didn't touch is the juvenile T inversion patterns. The athletic heart will have all these things, then early reposition. All these are all normal variation. Now coming to your question about 34 heart rate. See, as the athletes, they have a very high vagal tone. Because of that, their heart rate, basic heart rate, intrinsic heart rate is lower, less than 50. By definition, it is sinus bradycardia. But they can increase their heart rate to 180 in a short span. So their heart rate variation from bradycardia to tachycardia occurs in a short span. That means that so much of vagal tone they have. So it is considered as sinus bradycardia by definition, but it is not pathological in athletes. In fact, some of the Holters done in athletes, they can also have a transient complete heart block or second degree AV block also. But it is considered as non-pathological. Yeah. Therefore, see, when we analyze the Holter, we always connect we look at the timing of connection as well as when we connect a Holter, number one, and when we are assessing, suppose if we are assessing their rhythm, particularly whether it is a sinus bradycardia or a AV block or a Wenckebach, whatever is that, we look into consideration the time when it is. In a waking time, it should be when they are awake, then it is considered as pathological. But during the early morning hours of sleep, it is we have to look at different aspects, because that is a possibility of a normal variation also. That depends on, most of the time sinus arrhythmia is present in athletics. So if people who are physically active, probably we find this. Young people who are physically active, particularly male preponderance, we get sinus arrhythmias. So it is. Pardon? No, it is normally considered as 10% of them can have a variation. But it depends on what type of patients you see, because if they are young people who are very active physically, probably we get more incidence of sinus arrhythmia. Yes.
We know that this QRS is mostly related to potassium movement and sodium movement. But during the ST segments, we know it is related to the calcium influx. But how come it is always isolated?
Isolated means, like, I didn't understand.
This segment is always isolated.
Yeah.
Because there is an underlying calcium influx.
No, that is it is, I think, basically it is a combination of the factors which matters. Therefore, I think the depolarization, yeah.
But when you talk about normal action potentials, that phase 3 corresponds of calcium influx is the place where we get the ST segment.
Yes.
So, but our ST is always isolated. It doesn't seem to show any.
No, there is a small deflection is only seen, that is acceptable as a ST segment, less than 0.1 millivolts. But that is again the correct with this whatever you explained the same way. I think more than that, you mean to say why there is no ST?
Yeah, why there is no ST shift here?
ST shift. I do not have answer for that.
Maybe it's because it's slow calcium channel
Slow pathways also plays a role in this.
compared to the potassium channel and sodium channel. The calcium channels are slow.
Yeah, definitely. That may be the reason for the ST segment being more like an isohydrate. Yeah, that's the thing.
Sir, can you just elaborate a little bit about QT interval and keeping in mind when we should not give patients amiodarone?
No, other thing is that amiodarone is a class 3 antiarrhythmic, and naturally the QT interval gets prolonged. When we look at that way, I think I think 0.45 is the upper limit for the QTC when we take it. But when we look at the importance of amiodarone when we use it, I think we can start if somebody has got a 0.45 QTC, we will start on amiodarone and keep watch on the QT interval, how it prolongs during the therapy. Then we can take a decision. Suppose if it crosses beyond 0.56, I think we should be careful. Otherwise, up to from 0.45 to 0.56, we can think the therapeutic utility of amiodarone can be considered. Both amiodarone as well as sotalol, which are class 3 drugs. To 0.56. Pardon? That is the next topic. I think they will be covering that, yes. I think I have exceeded my time, I think. Thank you very much.
Thank you, sir. I now request Dr. Narasimha Hegde, ex-HOD and Professor of Medicine, Father Muller Medical College, to hand over a certificate of appreciation for the talk to Dr. Subramanya and Dr. Manjunath BV. Thank you, sir. For the next talk, we have Dr. Narayana Bhatt from KMC. He's an intervention cardiologist. He will be speaking on determination of QRS axis and its importance. Dr. Narayana Bhatt.
Good afternoon, everybody. At the outset, I would like to thank Dr. Prabhakar and his team for giving me an opportunity to come and speak some thoughts about the electrical QRS axis and voltage criteria for diagnosis of chamber hypertrophy. So, electrical axis, as you all know, is formed because of the depolarization of both the right ventricle and the left ventricle. The mean QRS voltage of the depolarization of these two chambers results in what is called as the mean QRS axis of the human body. So, the net result is a axis, the mean of which is about 59 degrees positive. However, it has got a range in different individuals ranging from minus 30 degrees to plus 90 degrees. So, if there is a deviation of this electrical axis above minus 30 degrees, we call it as left axis deviation, or if there is a deviation to plus 90 degrees or more, we call it as right axis deviation. There is also called as extreme right axis deviation, or also called as the northwest axis, where the axis deviation is beyond plus 180 degrees. However, it is quite rare phenomenon. So, the basis of this identification of this electrical axis is, as Subramaniam has told, is based upon the nth of 1's triangle and the limb leads, where lead 1 forms the base, the lead 3 and lead 2 are the right and left hand sides of this triangle. So, all the leads together along with the augmented leads that he has spoken about will form an electrical axis of the heart, which we have to remember mentally in our mind to identify the electrical axis of the particular person based upon the ECG. So, you require the 6 limb leads to identify the electrical axis of the individual. So, the normal axis, as I told, is ranging from minus 30, which is formed by the AVL lead, to the plus 90 degrees, which is formed by the AVF. So this is in general the normal axis, and AVR and lead 3 form the abnormal axis and right axis deviations. So how do you estimate the axis of the particular ECG? So a simple rule is helpful. So we can identify the 4 quadrants into which the axis belongs instead of pinpointing the axis accurately at the bedside of the patient. So how to do it? You can take 2 leads. There are several methods available. One of the methods is the following, which I am telling you, that is lead 1 and AVF. If lead 1 and AVF are both towards the positive deflection, then it is the normal axis, that is the right lower quadrant. If lead 1 is positive and AVF is predominantly negative, usually that means patient has left axis deviation. And if lead 1 is predominantly negative and AVF has got predominantly positive deflection, that means patient is likely to be having the left lower quadrant, that is the right axis deviation. That is where the electrical axis will lie. And the extreme right axis or the northwest axis will be there when both 1 and AVF will be having negative deflection. In such an ECG, you will find that the AVR, instead of being negative deflection, will be showing a positive deflection predominantly. Coming back to the previous slide, in a rule of thumb, you can also use a single lead also to identify where the axis belongs. That is, if the predominant R wave is in the lead AVL, that is the height of the R wave in AVL is more than the lead 1 and other particular leads, then it is likely that patient is having a left axis deviation. So if the predominant R wave is in lead 2, then definitely compared to the other leads, then definitely patient is having a normal range of QRS axis. If the predominant R wave, the height that is of lead 3 is much more than AVF or other leads, definitely that means the axis is towards the right side. Or if the predominant R wave is present in AVR, which never has really a big R wave, then that means the patient has northwest axis. So this is also a rule of thumb, a simple equation which can be used in at least 90% of individuals, it found to be right. So these are the 2 simple methods of finding out the correct QRS axis based